Hi, this is Erin from Educated Nurse and welcome back to our channel. Today we're going to do a lecture on one of my favorite topics aside from EKGs, and it's going to be on fluid balance and IV solutions, electrolytes, and then ABG analysis. So we're going to dive into those. They're going to be 3 separate lectures, so look for all 3 of them. And if you're struggling with this, definitely check out the Etsy shop. We've got study guides that breaks down all 3 of these things a little bit farther, and there's practice questions if you like the questions that we cover in the lectures too. Also, if you're new to us, make sure to follow us on Facebook, Instagram, and TikTok, and check back on our YouTube channel. We're putting up different topics from various different body systems every week, so check back there. And then lastly, if you're looking for any merch or gifts or stickers or anything, definitely pop over to the Etsy shop. We've got tons of stuff for all the healthcare workers in your life. All right, so let's dive in to one of my favorite topics. Here we go. So to start off, if you don't know me, this is just a little information about me when you can read about it on your own time. I'm also just going to include a disclaimer that all the information that's presented is really just for continuing education and training purposes. If you are working in a hospital or you're working in an EMS agency, you really just need to treat patients in accordance with your medical direction and your EMS and hospital policies, as it certainly could be different than the information that I'm providing you. All right, let's get started and dive into fluid balance. Let's look at some fluid considerations. First of all, where do our fluids live? Well, 60 to 70% live inside the cell, or what we call intracellular, inside the cell. 30 to 40% approximately live outside the cell, or extracellular. 20% approximately fluids make up part of our plasma. And there's 10% that's not in the blood, which is what we call interstitial, what surrounds the cell. Fluids within the body help us with 4 main functions to help maintain homeostasis. 1, fluid helps us with temperature management, like when we have a fever and we start sweating, that's our natural way of cooling ourselves down. Transportation, and when I say transportation, that's like nutrients from cells to tissues and the bloodstream, etc. Lubrication, and then digestion. There are many regulators of fluid balance: the hypothalamus, the pituitary, your adrenals, which sit on your kidneys, your renal function, cardiac, GI, and then you also have insensible water losses. And we're going to talk about these a little bit more in depth coming up. When we think about fluid movement, we need to kind of consider what happens on the arterial end of a capillary and what happens on the venous end. We're going to break this down a little bit. But you have to understand 2 different types of pressures. There's hydrostatic pressure and oncotic pressure. Hydrostatic pressure is greater at the arterial end versus the capillary or venous end. On the arterial end, hydrostatic pressure pushes fluid and electrolytes out of the capillary and into the interstitial space. Because of the size and the shape, red blood cells, some plasma, and large proteins such as albumin stay in the vessel. When that hydrostatic pressure pushes those fluid and electrolytes out of the capillary or the vessel into the interstitial space, the tissues and the organs soak them up and take what they need to function. Then, when all the tissues and organs and cells within the body are done using all of that up, they're going to go into the venous end of the vessel via oncotic pressure. Oncotic pressure is created by protein molecules in the vein, such as, again, albumin. On the venous end, the waste and the fluid gets pulled back into the vessel, and it then goes off to the kidneys or the colon and gets excreted as waste. When we have low albumin levels, with oncotic pressure, extra fluid will remain in the interstitial space or the tissue, and then your patient is going to become edematous. All of our body systems are interconnected when regulating fluid balance. Let's break them down. The hypothalamus, which is in the brain, has receptors within it. Receptors sense fluid loss or influx, which then stimulates ADH release, which then results in increased free water and decreased plasma osmolality. The pituitary releases ADH, which causes the kidneys to return water to the blood and less water is excreted in the urine. So you're going to hold on to it. Your adrenal cortex, which sits in the adrenal gland on top of your kidney, releases aldosterone. Kidneys return sodium, chloride, and water to the blood, and potassium and hydrogen are excreted in the urine. This is going to make a little more sense when we look at acid-base balance. In your kidneys itself, the primary regulator of fluid balance is actually the kidneys. Kidneys adjust urine volume and excretion of electrolytes, and kidneys need adequate perfusion from the heart to function. If you don't have enough blood flow to the kidneys are not going to work. They're not going to excrete, and they're actually going to hold on to urine, and you'll notice that your patient will have decreased urinary output. In your heart is going to increase blood pressure to increase circulation. The cells within your heart are going to produce BNP, and that's what happens when blood pressure rises. It's going to produce BNP, which is an antagonist to the RAS system relating to the kidneys. Your GI system, your oral intake is most of your water consumption. Feces release a small amount of water unless your patient has diarrhea. And diarrhea and vomiting can lead to significant fluid and electrolyte losses. And again, we'll touch on that when we hit on ABGs and acid-base imbalance. Insensible losses, you can't really measure this. This is that invisible vaporization from your lungs and skin what helps regulate body temperature. So like I said, whenever you have a fever and you start to sweat, that's your body's way of regulating body temperature, and you sweat to cool yourself down. When you talk, you lose that insensible water loss every time you talk as moisture leaves your mouth through the air. Again, hard to measure, but it can happen. Let's look at fluid volume deficit versus fluid volume overload. Fluid volume deficit is an abnormal loss of body fluids. Usually it's through diarrhea, bleeding, polyuria, which is peeing a lot, and potentially fistula drainage. There are other causes for fluid volume deficit, but GI losses and bleeding are your biggest. It can also happen with inadequate intake of fluids, water especially. When we have fluid volume deficit, those fluid shifts from plasma to interstitial fluid aren't going to be as pronounced. When someone has low circulating fluids, so they're kind of like dehydrated, they're going to experience neuro changes, so they could be anxiety, they can be confused, weakness, they're going to be thirsty. You'll notice dry mucous membranes, decreased skin turgor, decreased capillary refill because they don't have that circulating volume, postural hypotension, so as they go from laying to sitting and sitting to standing, you'll notice changes with their blood pressure. And again, that's because of fluid shifting and not having enough fluid to circulate around the body. You're going to have increased pulse because the body's going to try and beat faster to circulate a lower amount of volume to everywhere it needs to go. Tachycardia, which is the same thing, decreased urinary output, and it's going to be concentrated. So like you've seen patients that have been dehydrated, right? Their urine is really dark and concentrated, and it'll be decreased because they're not taking in enough and the body's taking what it needs, and so they're going to have decreased urinary output. Increased respiratory rate, and that comes with tachycardia. Dizziness could be a neuro change, weight loss, and then seizures and coma can actually happen, especially if there's an alteration with sodium. And we know that water follows salt, so if the patient is dehydrated, they're probably going to be deficient in electrolytes as well. And then we really start to worry about sodium, potassium, magnesium, calcium, especially those because they are going to help deal with the cardiac body system. So we need to be really careful with that. We'll talk a little bit more about that when we get to electrolytes, but seizures, coma, and neuro changes go highly with sodium and that being decreased. So those neuro changes, if you're noticing that your patient's dehydrated and they're showing signs of neuro changes, one of the first things I would do is get an electrolyte panel because the sodium is probably off. On the flip side, fluid volume overload, most of the time this happens because of excessive intake of fluids. So the patient is just drinking. It can also happen from retention of fluids and the patient becomes edematous. However, if your patient is edematous, they can still be dehydrated,
especially if that fluid is sitting out in the tissues and it's not actually circulating in the vessels. One thing you'd want to look for at that point is to look at that albumin level, which is usually on a liver panel. Symptoms of fluid volume overload, again, neuro changes, especially if salt is in play. In fluid volume overload, there's going to be extra water, but the salt is going to be diluted, so they can still have neuro changes. Lethargy, peripheral edema, again, they're going to have all that extra water, especially out in the periphery. Jugular vein distension, a bounding pulse, increased blood pressure, and tachycardia. And on this side, we can say, well, Erin, they had tachycardia on fluid volume deficit. That's true, but they have tachycardia on fluid volume overload because there's more volume and the heart has to work harder to push that fluid around. Polyuria, if they have normal renal function, if they have fluid volume overload, you might notice that they're going to have polyuria and start peeing a lot more. With fluid volume overload, one of the things that we worry about the most is when extra fluid then sits in the lungs too long. So then we start to worry about the patient getting short of breath, having crackles, getting pulmonary edema. And again, if your patient is fluid volume overloaded, they've got too much fluid on board, we absolutely start to worry about ABCs, airway, breathing, circulation, and we should be looking at that breathing component. If you have a patient that's fluid volume overloaded and now they're getting crackles, that means that fluid is sitting in their lungs and that's going to become a breathing problem real quick. So we have to deal with that. Weight gain, again, a lot of that's going to be due to the edema. And then again, seizures and coma, same thing as deficit. And again, a lot that has to do with the sodium level. All right, let's briefly look at the two main types of fluids, and we're going to break this down even farther, especially on the crystalloid section about the different types of fluids. But typically there's colloids and crystalloids. Colloids contain large molecules that do not pass through the semipermeable membrane. Colloids are used to increase that osmotic pressure that's on the venous side to help pull that fluid from the extravascular space into the ECF. And that'll then get into the vessels and then you pee it out. Colloids can also be considered expanders or volume expanders because it stays in the vascular space. An example of a colloid would be plasma or albumin, like we talked about previously. And again, these are large molecules that don't pass through the vessel. They stay in the vessel, but they create that extra pressure to pull water back into the vessel so it can be excreted. Crystalloids are solute liquids. They have electrolytes and non-electrolytes. They're easily mixed and dissolved in a solution. They contain small molecules that flow easily across the membrane, and they allow transfer from bloodstream into the cells and into the body. So it helps kind of that fluid movement from the blood vessel into the cells and tissue to transfer off the good nutrients and oxygen and everything that the cells and tissue and organs need, and then it pulls it back in. Many increase fluid volume, and we're going to look at that. Some just expand the vessel, some expand the cell, some shrink the cell, so we're going to look at those. Examples of crystalloids are your isotonic solutions, hypotonic solutions, hypertonic solutions, and your dextrose solutions. You also have some that are just water, and we'll touch on that in just a moment. Fluid considerations. When you're thinking about what fluid is appropriate, you want to think of two different things. One, how does it affect the cell? And two, how does it affect the vascular space or the fluid within the vessel? Let's start with isotonic solutions. Isotonic solutions have a concentration that's very similar to our own body's plasma. The osmotic pressure is constant inside and outside the cell, so fluid remains in the vessel. There is no shifting. There is some fluid within the cell, but again, there's no shifting. Cells don't shrink or swell. All you're really doing with an isotonic solution is expanding the volume within the vessel or the ECF. Some examples of isotonic solutions are 0.9 normal saline or NS, which is basically salt water. It's got water, sodium, and chloride. It's compatible with most medications, and it's the only one that you can use when you're infusing blood. Now, If you have a patient that has heart failure or renal failure, you have to be very careful because it can be a risk for fluid volume overload. Lactated Ringer's is also another great isotonic solution. It's similar to our blood serum and plasma, but it contains electrolytes. So it's similar to normal saline, but it has electrolytes like potassium in there. D5W, which is dextrose 5 in water, is a dextrose solution, which in the beginning it starts off as an isotonic solution. However, once that sugar gets burned off, it actually switches over to a hypotonic solution. So with an isotonic solution, the amount of water inside the cell and inside the vessel remain the same. The cells don't shrink or swell. All you're doing is adding extra volume to the blood vessel itself, the volume. In a hypotonic solution has a lower concentration or tonicity of solutes or electrolytes. This lowers serum osmolality within the vascular space. Fluid shifts from the intravascular space to both intracellular and interstitial spaces. So what happens is a hypotonic solution has a lower amount of salt than an isotonic solution. So when you put in a hypotonic solution, there's actually going to be more salt within the cell, and the hypotonic solution is going to try and take water and put it inside the cell to help dilute what's inside the cell to make inside and outside equal. So it's going to plump up the cell with water because there's going to be more salt in the cell, and the fluid outside the cell isn't going to have as much. So it's going to try and shift water into the cell and blow it up so it equalizes. This hypotonic solution has more water than it does electrolytes. The bummer with a hypotonic solution is that it's going to dilute the extracellular fluid. And in some patients, it's actually going to dehydrate them. So you have to be very careful. So if you have a patient who's already dehydrated, a hypotonic solution is probably not the best solution to choose because you are at risk for further dehydrating them when it pulls that water out of the vessel to plump up the cell. Some examples of hypotonic solutions, D5W, like we already talked about, and then you've got 0.45, which is half normal saline, and then 0.225, which is a quarter normal saline, which isn't listed on here. But if you think about 0.9% normal saline as your isotonic, anything below 0.9% is going to be hypotonic. Anything greater than 0.9% is going to be hypertonic. So let's look at hypertonic. Hypertonic solutions have a higher tonicity or solute concentration. Usually there's unequal pressure between the inside and the outside of the cells. It's going to raise osmolality of the ECF and draw water out of the cell. So the cell is going to shrink. So in a hypertonic solution, there is a ton of salt in those fluids. And again, because there's so much salt in the fluid, when you dump that into the blood vessel, the little cells are going to be like, oh my gosh, we are swimming in a very salty hot tub, right? So the cells are going to be like, I'm going to try and contribute and try and dilute that vessel full of salty water, and I'm going to pull water out of my cell to help dilute the vessel. So your cells are going to shrink, and all the water from the cell, not all, but a lot of the water from the cell is going to be pulled out and pulled into the vessel to try and dilute that really high sodium content. In a hypertonic solution, this can be used as a volume expander. Now, I've said it before, and I'll say it again, and probably again and again, water follows salt. Water follows salt. So if you are going to give a hypertonic solution, you have to watch if your patient gets edematous. You have to monitor ABCs. This can absolutely cause fluid volume overload. So you have to monitor vital signs, monitor ABCs, watch their electrolytes, especially their sodium. You have to. Water follows salt. So if you're going to put in a really salty solution, you got to expect that there's going to be some fluid shifting happening here. An example of a hypertonic solution would be anything greater than 0.9% normal saline, like I said. So you're looking at your 3, 5, 7, and 9% normal salines. 50% dextrose or D50. Another thing would be 5% dextrose in half normal saline. And your other one, which is D10W. So this is dextrose 10 in water. So this is going to provide a good chunk of dextrose, similar to your D50. If you're going to be pushing D10W or D50 for a long period of time, you really should consider a central line, because it can be really irritating to the vessel to be infusing that for a long time. Next up, we're going to look and see what kind of patients would get these different types of fluids. All right, so let's briefly look at who gets what kind of IV fluid. And again, these are all going to be prescribed by a doctor, but if you're a nurse or you're a paramedic or an EMT or something and you're thinking about what kind of fluids would really benefit my patient, I want you to think about these things in kind of anticipation for that order, or if you have standing orders, great, enact them if you need them. So isotonic fluids, we talked a little bit about this already, but 0.9% saline or NS. Typically, normal saline is going to be given to patients with GI/GU losses, so your dehydrated patients, patients with burns, trauma, if they need fluid replacement. It's the only one that can be given with blood products. But again, remember, be caution with cardiac patients, patients with kidney failure, and patients who might already have pulmonary edema, because we can fluid volume overload them with this. Lactated ringers. Lactated ringers is perfect for your GI/GU losses because it has electrolytes in there. It's also great for your patients that are NPO. So maybe you've got a patient that has an NG tube in, or they are preparing for surgery and they can't eat or drink anything. So it's got those electrolytes in there to help boost that if they're dehydrated or they have to be NPO for whatever reason. Burns again, fistula drainage, trauma. Again, caution in heart and renal failure. And also you have to be careful with this one for patients who can't metabolize lactate. So patients with liver disease or acidotic patients. If they can't metabolize the lactate, all you're going to do is have extra lactic acid that builds up, which is going to make them further acidotic. So you have to be careful if a patient has liver disease, they might not be able to process the lactate part of lactated ringers. D5W can be used as a volume expander, can also be used in hypernatremia where the salt is high. It's not good for fluid resuscitation. You really need some salt content and some electrolyte content in there. Okay, hypotonic solutions. Most of these are going to be the same in terms of who they could be given to. But like you think about your quarter normal saline or 0.225 normal saline. These could be your hypovolemia patients potentially. Again, if they're super dehydrated, you got to be careful with those. Sometimes this is used in maintenance in PEDS patients. It's typically given with dextrose. It can lead to hyponatremia, and you should avoid it in patients with liver disease, trauma, burns, and then increased intracranial pressure. This is a big no-no. Don't ever give a hypotonic solution to a patient with increased intracranial pressure. All you're going to do is take fluid from the vessel and plump up the cell and increase their intracranial pressure. 0.945% normal saline or half normal saline. Again, it can be used for patients who have high salt, and you just got to get them a fluid without a lot of salt content. Be careful though, because it's going to cause a little bit of dilution. It can actually lead to hyponatremia. D5W is great if your patient can't get any salt, right? It can also be a volume expander, and it's great for your hypernatremia patients. It's not used for fluid resuscitation. Lastly, hypertonic solutions, your 3, 5, 7, 9%. This is for acute treatment of hyponatremia, so when the salt is low, or when your patient has increased ICP, because we know the hypertonic fluid is going to shrink the cells. So if you have a patient with increased ICP, you would consider a hypertonic solution to shrink the cell and decrease that cerebral edema in the head, because then it'll go into the vessel and hopefully you'll excrete it. When you have a hypertonic solution, it's super important that you infuse it slow to avoid pulmonary edema. You should be monitoring vital signs and ABCs before, during, and after the infusion. Again, these hypertonic solutions, they can be really irritating to the vein. So if you're going to give them long term, it really should go through a central line. D10W is often used in patients that are acidotic or in ketosis, or if they've had malnourishment or starvation. Again, use it through a central line if possible, and watch your labs. It can cause red blood cell hemolysis, so you got to watch your CBC counts. And then lastly, D50 or dextrose 50 is used for severe hypoglycemia, and usually it's given rapid IV bolus. You're not really going to do an infusion of this unless the patient really has some long-term hypoglycemia issues. Again, consider a central line if need be. Most of the time, these things are going to be IV push. And it's not super common. I have seen it, but not super common to do an infusion. So those are just some examples of what kind of patients might get these different fluids. All right, so I just want to touch quickly on different fluid considerations for pediatrics versus geriatrics. Pediatrics have a higher percentage of body fluid, right? They're nice and squishy and fatty and roly-poly, so they have a higher percentage of body fluid. Until they're age 1, they really have a lesser ability to concentrate urine compared to an adult. So they might struggle with fluid and electrolyte imbalances here. They're going to dehydrate way quicker than adults, especially if it's just 10% of their body weight. I mean, you have a 10-pound baby, a newborn, right? And they lose 10% or 1 pound of their body weight. It's not going to take very much for them to get dehydrated. In comparison, pediatric patients have a greater body surface area compared to an adult. If you think about just, spacing of body surface, an adult versus a kiddo. They have a less robust immune system, especially up until that 6-month period where they're really getting into their vaccines. And if you have a pediatric patient, especially an infant or a small child who has any sort of ongoing fever greater than 100.8, 100.7, somewhere in there, and they're vomiting and diarrhea, they really should be getting treatment if they're not able to keep anything down and they've got this ongoing fever. To assess a pediatric patient with this, it's always a good idea to ask mom or dad, are they peeing and pooping okay? Are they making tears? Are they making wet diapers? Check for those fontanelles. Are they sunken in? Look at their skin color and turgor. And we always say, how can we measure INO? It's super important that in an adult patient, we're getting those daily weights right away in the morning before they get up, before they put clothes on. Right? Or right after they get up, but before they put clothes on. In a pediatric patient, daily weights are important, but also weighing their diapers to see how much they're actually peeing, and, intake you can kind of measure via bottles and that kind of stuff, but output, it's a good idea to measure those diapers. In a geriatric patient, as we age, we have a decreased ability to conserve water. We have a decrease in ADH and ANP. Most geriatric patients have a lack of thirst, so they're just not thirsty. They don't want to drink. And they typically have dry mucosal membranes. With a geriatric patient, when you're thinking about assessments, they might have very non-specific complaints. Like they might just say something like, I just don't feel right, I don't feel good, I'm just more tired than normal, or they just think it's a normal sign of aging. You might notice neuro changes, especially if their sodium is off, right? You're going to notice that irritability, confusion. And then if they have increased A risk for dehydration too. You also have to think about infection, especially UTI in the geriatric patient. Other things to consider, again, thinking about daily weights, I&Os, measuring those is important. And then with your geriatric patient, because they have that lack of thirst, even though they might not feel thirsty or want to drink something, it's a good idea just to give them a water bottle and tell them like, hey, while you're watching TV, every time there's a commercial, take a drink. Or every hour, set an alarm for yourself, take a drink. Something like that, just to get them to do that, because they won't have that thirst mechanism to get them to want to drink. And it's really easy for them to get dehydrated. Okay, the teacher in me has a couple practice questions here for you. So you're working in the ER when an 87-year-old male with COPD and CHF comes in complaining of 2+ pitting edema in the lower extremities and dyspnea on exertion. So kind of expected findings with those two disease processes. Nothing real new or acute happening there. He hasn't been able to eat or drink since he ate bad Chinese food 3 days ago. Being the intelligent nurse that you are, what IV solution do you anticipate the doctor ordering? Think about this. And think about what's expected for the disease process and what's not expected. Like we said, that pitting edema and the dyspnea on exertion, those are expected findings with COPD and CHF. So there's nothing really acute happening here. His acute problem is that he hasn't been able to eat or drink since he ate bad food 3 days ago. So he's got some GI losses going on there. So what IV solution do you anticipate the doctor ordering? Think about it. All right, if you said lactated ringers, you would be correct. Again, what's expected versus not expected? The guy's dehydrated, right? So he hasn't been able to eat or drink in 3 days. Do we care about his COPD and CHF? Yes, we do. But he's clearly dehydrated. He's got some GI losses. For GI losses, we want to do lactated ringers or normal saline. Okay, another question here for you. A patient has a diagnosis of decreased cardiac output related to deficient fluid volume. What assessment findings support this diagnosis? A, bulging neck veins when the patient is supine. B, full and bounding pedal pulses. C, pitting edema in the bilateral lower extremities. Or D, sinus tachycardia. So deficient fluid volume, what would you see? If you pick D, you're correct. All the other ones, A, B, and C, are signs and symptoms of fluid volume overload. Well, you could say sinus tachycardia is overload also, but that's the only one that matches with the fluid volume deficit. The other ones are clearly fluid volume overload. All right, thank you for joining my lecture on fluid and IV solutions. Check back and check out our other presentations on electrolyte and then acid-base imbalance, kind of in this 3-part series. Here are my references. If you have any questions, don't hesitate to reach out. Make sure to follow along on Instagram, Facebook, and TikTok. And if you're looking for more information, or you have other questions, or if you're looking for any merch or gifts or anything for the healthcare people in your life, check out my Etsy shop. I sell study guides and practice questions for students who just want a little bit more practice with this. And again, like I said, reach out anytime if you have any questions. Hope to catch you in the next lecture.